You want to work for the FBI? You got a resume, I'll send it. You out of Fort Worth or Dallas? Where'd you go undergrad? I went to
Committee is in order. We don't need to say that we need to get in order. We want to thank our second panel for being here still this morning, and we have with us Ms. Lucinda Jessen, who is the Commissioner of Minnesota's Department of Human Services. We have Ms. Cindy Mann, Director of Center for Medicaid State and Operations for the Centers for Medicare and Medicaid, and of course Ms. Carolyn Yoakum, who is the Director for Health Care at the U.S. Government Accountability Office. We have to do the same routine, so if you'll stand up and raise your right hand. Do you solemnly swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth? Let the record reflect that all of our witnesses answered in the affirmative. You get 5 minutes. You guys know the drill. We will include all of your written testimony in the record, but if you can keep it to approximately 5, that would be great, because I know that Mr. Gotti, Mr. Kucinich, Mr. Davis, we have some questions for you. So, Commissioner, we'll go right down the list, and you're up first.
Mr. Chair, members, my name is Lucinda Jessen. I'm Commissioner of the Department of Human Services for the State of Minnesota. And thank you for the opportunity to discuss Minnesota's Medicaid program. You know, Minnesota is a leader and has been in using managed care to serve its Medicaid population. And I was happy to accept this invitation because as more and more states move Medicaid populations into managed care, there are a lot of lessons to be learned from Minnesota. Lessons about what works and lessons about what needs to be done differently, both types of lessons. First, let me talk about what works. Access, quality, innovation, and delivery models. Minnesota has placed a high priority over many years in providing good access to health care for its low-income citizens, and managed care is available to enrollees statewide through our nonprofit HMOs and county-based health plans. And let me be clear, managed care has been critical to providing access to health and long-term care services for our Medicaid population. You often hear in other states that having public insurance doesn't mean much if you can't see a doctor. Not in Minnesota. Overall, our enrollees have access to quality care. What needs improvement? Better contracting, being a smarter purchaser of health care, and, frankly, increased oversight. And let me address each of these concerns and briefly outline the steps Minnesota has taken over the past 15 months since Governor Mark Dayton took office to address them. When Governor Dayton and I took office last year, we had serious concerns about how the Department of Human Services, under the previous administration, had purchased health care for its Medicaid managed care program. We also had concerns about the transparency and oversight of the contracting process itself. Our concerns stemmed from increasing profit margins that health plans earned from public programs, the particularly high level of health plan reserves, and I attached some charts on these things to my written testimony, which resulted in part, these reserves, from profits on public programs, and we had concerns about the contracting process itself. We were struck that the contracts we inherited from the previous administration offered few incentives for improving quality and reducing costs. Moreover, at a time when the private sector was making considerable progress on payment reforms, doing more creative things, the state contracts remained stuck in the old way of doing business. We also felt that the actuarial soundness requirement was inherently inflationary, because you ended up setting rates in the future based upon what had happened primarily what had happened in the past, and we questioned where the incentives were for more efficiency. So while there are and were many positive aspects to managed care, there was also a lack of creativity and a lack of focus on value on how health care was purchased in Minnesota. And we moved very quickly to address those. First, we addressed the 2011 contracts we inherited by asking all 4 major health plans to voluntarily agree to cap their 2000 earnings at 1% of operating margins for our programs. And I want to thank the plans for agreeing to that. Earlier this month, we announced that an estimated $73 million will be returned to the federal and state governments due to this cap on excess profits. And when you add that to the $30 million from UCare, which we have agreed with CMS to treat under that 1% cap so that the federal government is returned its share, when you add those two together, you have over $100 million we recovered for federal and state taxpayers from the previous administration's 2011 contracts. But we didn't start there. Just a little over a month after I took office, we put the major health plan contracts for the Twin Cities metropolitan area out for bid. In the past, DHS, working with its actuaries, basically set capitation rates, and any plan could participate if they accepted those rates. Those rates were approved by CMS. But under competitive bidding, we changed the incentives. Plans had an incentive to give us their best proposal in terms of cost and quality. And there were winners and losers among the health plans, but the real winners were the federal and state taxpayers who, under the new contracts, had $175 million in savings to the state and an equal $175 million to the federal government. When you combine this with our other managed care reforms that we passed with strong legislative support, our managed care reforms totaled over $600 million, and that's in addition to the $100 million from the cap in savings to the state and federal government. But we need to not only be a smarter purchaser of health care, we need to increase the oversight of these large contracts, and no one believes that more than I do. In Minnesota, there are, as you have heard, very real questions and some mistrust over where these billions of dollars are going. And that is why Governor Dayton, just 2 months into office, ordered additional audits of the health plans, and those audits started this month. They're being conducted by outside vendors contracted by the Minnesota Department of Commerce. Additionally, at DHS, I created the Office of Inspector General to enforce increased program fraud detection and prevention efforts. We also changed the contracts we had with the health plans to have better compliance, and we added reporting requirements about what they were doing on their own program integrity office. And finally, as someone mentioned, the Human Services Bill, which just passed our legislature and is headed to Governor Dayton's desk, requires a requirement for third-party financial audits in addition to the ones the Governor has ordered. And these audits will strengthen our oversight. They'll be done conducted through our Legislative Auditor's Office, and Governor Dayton strongly supports this requirement. Minnesota has long been a leader in how managed care plans serve our Medicaid enrollees. but changes needed to be made in the way we do business now and in the future. We've made an unprecedented number of them just in the last 15 months, and we're not done. Thank you.
Thank you, Commissioner. Director Mann.
Good morning. Chairman Gowdy and Gordon, Ranking Members Davis and Kucinich, and members of the committee, thank you for the invitation to discuss Medicaid's financial management. No matter could be more central or important to the Medicaid program or indeed to any health care program. Medicaid, as you all know, is the primary source of medical assistance for millions of low-income, disabled, and elderly Americans, children and adults alike. In fiscal year 2012, an estimated 56.6 million people will receive their health care coverage through the Medicaid program. The Medicaid program establishes at the Federal level, we establish minimum requirements. States design, implement, oversee their Medicaid programs, and federalism is the hallmark of the program. Our basic financial management arrangement works as follows. States pay for the health care benefits provided to eligible individuals, and the Federal Government in return matches qualified State expenditures at a rate that varies between 50 and 75%. On average, States are responsible for about 43% of program costs. The matching structure ensures that both the States and the Federal Government have a very strong fiscal interest in assuring that the program operates efficiently. I'm going to use my time this morning to briefly describe our methods of financial oversight that relate specifically to the issues raised at this hearing. But let me first make a few quick observations. Medicaid, like other payers, is very interested in supporting new ways of delivering and paying for care to promote better care at lower costs. Fortunately, we have at our side something most payers don't have, which is 50 State partners. We have a number of States that have been approved to operate and create health homes that are looking for shared savings arrangements with their providers, and States as diverse as Texas and Massachusetts that are redesigning in fundamental ways their Medicaid delivery systems. Second, because Medicaid, like the marketplace generally, is experiencing significant change, our goal is not just to manage the issues that were identified last year or 5 years ago, but rather to develop new tools and methods to respond to and indeed to anticipate the changing landscape. Therefore, like many prudent purchasers, we value in our investing in data and measurement to assess what's working, to rapidly adjust when things aren't working, and to rapidly scale when things are going well. Improved data and measurement will take a while for us to fully implement, but it will allow us to better track costs, utilization, integrity, and quality. Third, nothing that has been talked about today is unique to Medicaid. Orthodontists doing improper billing, health plans overcharging, those aren't unique to the Medicaid program, sadly. The work that the Attorney General of the United States, that Secretary Sebelius have done to aggressively fight health care fraud with the private sector has focused on health care fraud more broadly, and the notion that it is a broad issue that affects public as well as private payers. We have a major responsibility to do so, but it is not a problem that's unique to either Medicaid, Medicare, or commercial payers. I'm going to now turn to a general description of our methods for overseeing the payment of Federal matching funds. States report their expenditures to us on a quarterly basis through an online system, and a team of accountants and financial management specialists review those States' submissions of expenditures. They review them carefully and approve them or defer them before we pay our Federal matching payments. Our teams also coordinate with State auditors and with the HHS Office of Inspector General to ensure that State expenditures and corresponding claims for Federal funds are allowable. And every year we also establish with our regional offices a work plan for an in-depth financial management review that reflects our assessments of risks. We might follow up with an OIG report that suggests a problem that might be widespread. We might focus on an area of spending that we think is prone to abuse. When we question expenditures, we defer payment. We defer the Federal funds to the States pending resolution, and then we disallow the funds for claims for which adequate documentation or justification is lacking. We are not, as Congressman Davis pointed out, we are not the fraud office, we are not the law enforcement office, but we of course work very closely with those offices as appropriate. And I might say in that regard that the Office of Inspector General, the HHS Office of Inspector General, the Department of Justice, has been involved in each and every one of the matters that we've discussed today, both in New York, in Minnesota, as well as in Texas. Let me turn next to our oversight of plans and provider payment rates. Under Federal Medicaid law, states are responsible for setting their rates to providers and plans in a fair and efficient manner, and assuring that plans and providers are paid enough so that Medicaid beneficiaries have access to care. Both of these elements of the equation are really critical. We and states must have measurement systems in place to assure that rates are sufficient to provide our beneficiaries with access to care. This relates directly to the matter that Representative Cummings mentioned earlier with respect to DeMonte Driver, who died for lack of being able to find dental care in the State of Maryland. We issued proposed rules on how we might monitor access last year and plan to finalize that rule later this year. At the same time, plans and providers must not be paid more than what is fair and efficient, or else the program is wasting money or spending money inappropriately. As a result, we set outer bounds in the Medicaid program. For example, we won't pay more than the upper limit of what Medicare would pay for certain classes of providers, and we require rates paid to plans to be actuarially sound and certified. And one very important control that is embedded in the structure of the program itself is that because states are spending their own money as well as Federal government's money, they will take every opportunity to act as prudent purchasers. We know, of course, that states also will seek to maximize Federal funding, and so we have measures in place to assure that states, in fact, pay their state share of costs. Turning specifically to the payment rates in managed care, we're grateful for the GAO for its work over the years and its recommendations specifically in 2010. We have taken those recommendations very seriously, and we're working towards implementation. We've made good progress, but more needs to be done. We have supported our regional offices through training and guidance. We are creating a stronger database for the evaluation of rates. We are developing an online system of contract review, and we are planning to strengthen our financial management and oversight to move more to a risk-based approach, modulating the depth of review based on risk factors. With respect to Minnesota, and I'll just be a moment, we are pleased to report, as the Commissioner noted, that Minnesota determined that it will provide appropriately, we believe, the Federal Government with its share of the UCare $30 million that was received by the State, and we're also have added, contrary to, I think, the implications earlier, in the terms and conditions to the waiver in Minnesota, very specific provisions to assure that there is increased oversight in the Minnesota plans, and we continue to work very closely with the State as we move forward. Thank you.
Thank you, Director. Director Yoakum.
Chairman Jordan and Gowdy, Ranking Members Kucinich and Davis, and members of the subcommittee. I'm pleased to be here today as you discuss oversight of the Medicaid program. The Medicaid program has been on GAO's list of high-risk programs for nearly 10 years, in part because of concerns about the program's fiscal management. CMS and its state partners continue to face challenges finding the proper balance between Federal oversight and states' flexibility to administer their Medicaid programs. Both the states and the Federal Government must take responsibility for managing program finances efficiently. My remarks today summarize some of GAO's prior work on CMS's oversight of 3 areas of the Medicaid program: states' rate-setting methodologies for capitated managed care, supplemental payments, and program integrity. Overall, our prior work has shown that CMS has faced challenges with the fiscal management of Medicaid in these 3 areas. First, with regard to rate-setting methodologies, in August 2010, we reported on CMS's oversight of states' compliance with actuarial soundness requirements, which govern the process used to develop capitated managed care rates. At the time of our reporting, we found significant gaps in CMS's oversight of 2 states. In particular, CMS had not reviewed one state's rate setting for multiple years, nor had it completed a full review of another state's rate setting since the actuarial soundness requirements became effective, which was in August 2002. Beyond these two states, we identified additional inconsistencies in oversight, raising concerns that CMS was not ensuring other states' compliance with actuarial soundness. In this same report, we noted that actuarial certification does not ensure that the data used to set the rates are reliable, because actuaries may not audit or independently verify these data. CMS's efforts to ensure the quality of the data used to set the rates were generally limited to requiring assurances from states and health plans. From GAO's perspective, these efforts do not provide enough information to ensure the quality of the data used to set rates. With limited information on data quality, billions of federal and state dollars are at risk for misspending. Second, for over a decade, we have reported on various financing arrangements involving supplemental payments that shift the costs from the states to the federal government. Our work has found that while a variety of congressional and CMS actions have helped curb such arrangements, gaps in oversight remain. Statutory changes have resulted in recent regulations that have the potential to improve oversight of some, but not all, supplemental payments. Effective in 2011, there are improved transparency and accountability requirements for supplemental payments to hospitals that treat large numbers of low-income and Medicaid patients. However, these requirements, such as facility-specific reporting, are not in place for other types of supplemental payments, which appear to be increasing. Because such financing arrangements effectively increase the federal Medicaid share above what is established by law, they threaten the fiscal integrity of the Medicaid program, and they damage the federal-state partnership. Last, in December 2011, we testified that a key challenge CMS faced in implementing its Medicaid integrity program was ensuring effective coordination to avoid duplicating states' program integrity efforts, particularly in the area of auditing provider claims. The largest component of the Medicaid integrity program, the National Provider Audit Program, has had disappointing results, as these overpayments identified by its audit contractors were not commensurate with its contractors' costs. For example, CMS's audit contractors identified about $15.2 million in overpayments in fiscal year 2010, but the combined cost of the National Provider Audit Program was over twice that amount, about $36 million. CMS has announced plans to redesign this program, but it remains to be seen if this redesign will achieve improved results. CMS's other core activities are broad in scope and raise similar concerns regarding duplication. On a more positive note, its collaborative efforts on auditing with states and CMS's Medicaid Integrity Institute, a national training program for state program integrity officials, both show promise. In particular, these efforts appear to promote effective state coordination and collaboration and show more promising results. Mr. Chairman, this concludes my prepared remarks.
Thank you. Thank all our witnesses. We will now yield 5 minutes to the Chairman of the Subcommittee, gentleman from South Carolina, Mr. Gowdy.
Thank you, Chairman Jordan. Director Mann, since 9:30 this morning, we have learned in that whopping less than 3 hours that there is an expert witness who will testify that perhaps as many as 90% of the cases in Texas were outside the guidelines. We have providers who are certifying otherwise in writing. You have before and after pictures. You have photographs of providers who are advertising free braces. So it would not be tough, I don't suspect, to send an investigator to these free braces clinics to find out what percentage of patients they actually denied as opposed to accepted. You have no study showing any higher rate of malinclusion in Texas than any other state. So with that bevy of evidence, what has CMS done about the Texas orthodontia scandal?
Well, several things that I'd like to note. First, there is an HHS Office of Inspector General is conducting an investigation now, as well as the Department of Justice, so they're deeply involved and actually just made an announcement about some agreements.
Have you talked to the Attorney General recently about this case to get an update on its status?
I have not talked to the Attorney General recently.
Have you talked to the United States Attorney and the appropriate district in Texas to get an update on the status of the case?
Yes, we have been in touch with the Office of Inspector General. We've been in our regional office has been in touch with them, and I've been in regular contact, I should say, with the state Medicaid director and with the commissioner of health in Texas.
Have any orthodontists lost their license to practice medicine?
I don't know that. You asked that earlier, and I thought that was an important question, and I have sought the answer to that. We don't oversee that, but I don't know the question. I do know that the orthodontists who, if they have built the Medicaid program, not properly built the Medicaid program, they should be terminated, not just from that Medicaid program, but from any Medicaid program across the country.
Which would be debarment, right? That's the phrase we use, debarred.
Well, our jurisdiction is to terminate them from participating in the program. We don't.
How about to disgorge them of the profits? Has there been any attempt at restitution or disgorgement of the profits?
My understanding, that's what the department. You'll have to talk to the Department of Justice. We can get you that information. But my understanding is, at least as to the corporation for whom they worked, some of them, that is part of it. Certainly, from our point of view, again, we are not the law enforcement arm.
I understand that. That's why I haven't asked you who's gone to jail. But you do have a role in getting restitution, do you not?
That is exactly right.
So I'm not going to ask you about prison sentences. I'll just ask you how much money you have collected in restitution.
We are looking at which claims were improperly paid, and we will defer all those claims and any that were improper.
How long do you think that will take? Because it just doesn't strike me as being that difficult of a case, to be honest with you.
Generally, when the Department of Justice is involved in an investigation, we usually wait until their investigation is complete so that we don't get in the way, but we will defer the claims pending the investigation. And
so you're going to insist that restitution be part of any criminal settlement with any of these orthodontists or corporations?
I can't comment on what will happen with respect to the criminal actions.
But you're going to ask for it?
I can commit that our authority is, and we will, defer and disallow any claims that were improperly paid.
All right. Commissioner Jessom, I want to read, do you know a Christopher Ricker?
Mr. Chair, that name sounds familiar, but I don't know who it is.
Well, I don't either, but this is what he wrote in an email. We do not want to give any appearances that the money might be coming to DHS. Parenthetically, it bolsters our argument with CMS that this wasn't a provider return and therefore doesn't need to be shared with them. I guess them being CMS, which may go to why you want to have telephone calls as opposed to emails. So I will ask you, why your preference for telephone calls and not emails?
Mr. Chair, actually, that email was talking, if you look at the whole chain of them, about two things. One of them, I was correcting a draft press release, and that was where I said it should be a donation. But it was also in my emails.
Well, let me ask you about that, because let me just, the context of it is, in order to have a good chance of keeping all this money, it must be characterized as a donation. It doesn't read, in order to keep the reader of our press release from getting the misapprehension, it must be corrected. It clearly is calculated to be able to keep all the money. Agreed?
Mr. Chair, UCARE, when they came to tell me about this, called it a donation. I was trying to characterize it the same way they had characterized it to me.
Well, if it were just to correct a press release, why would you say if a refund, feds clearly get half? Why wouldn't you say we just got to get the press release right?
Mr. Chair, there's as you know, a difference between a bona fide donation, which I believe this was, and a return of money. And I was trying to make that clear.
Is there a strict policy on emailing press releases? Is that why you asked for telephone calls instead of emails?
No, Mr. Chair. It's actually the reference to telephone calls was going back to an earlier part of that email where we were talking about informing the chairs of the legislative committees.
You certainly can understand how it might read otherwise, can't you, Commissioner?
If you only read that portion of the email chain and not the entire one, I understand that.
Well, what I'm reading is in order to have a good chance of keeping all this money, it must be characterized as a donation. Not that it must be a donation, it must be characterized as a donation. If a refund, feds clearly get half. Can you work with Scott on redrafting? Also, I thought we were going to handle this through phone calls. Surely you can see how a casual reader might get the impression that this was calculated to keep the full $30 million and not to correct some press release. Can't you?
What I was doing, Mr. Chair, was what I think my job calls for when someone makes a donation, and I think I have a good basis for that it is a donation.
But you have a lot of people making $30 million donations?
That is a really good point, sir.
So how many $30 million, if it's a good point, what's a good answer? How many $30 million donations did you have that you sent emails to make sure they were characterized correctly?
Congressman, I think that's an excellent point because this was a very unique situation and one which we didn't have a playbook for, where there wasn't a clear answer. We took one position, CMS took another, and I'm glad that we were able to resolve this by basically—
Well, I don't know that we have resolved it. The only thing that's been resolved to me is that there's a perverse incentive to keep as much of other people's money as you possibly can, even if it means recharacterizing something. That's the impression I got. And Mr. Chairman, I'm out of time.
I thank the gentleman for his important question. Before yielding to the ranking member, Mr. Kucinich, let me just ask you, Director Mann, when did you first learn about the situation in Texas? Was it through the media, through the press accounts?
It was
after it had become public knowledge. Is that when you first learned about it?
After it had become public
knowledge. What about the situation in Minnesota? When did you first learn about the situation?
Through the commissioner also of Texas, we talked about the problem.
After it had become public. What about the situation in Minnesota? When did you first learn about that? Was it after it became public knowledge through the efforts of Mr. Feinwalks and others?
Yes, after it had become public knowledge.
How many people work at Health and Human Services?
I don't have that number off the top of my head, but I'm happy to give you.
I think it's 65,000 is what I've been told. How many people work at CMS?
A little over 300.
And so, and that's 65,000 folks, 300 folks at CMS. Do you have anyone who, I mean, it would seem to me someone would be watching, particularly the Texas situation, where you've got one state doing more of this than the rest of the country combined, and yet the first time you found out about it is when the press broke a story on it?
Chairman, we do not pay claims directly. Do you
have anyone who does oversight at HHS?
The state pays claims, and then we would look and see what happens to those claims and whether those claims are legitimate claims. There were $200 million, as I understand it, in orthodontia claims in an account of about $2 billion spent for dental care that was rising. It should have been detected. It was clearly an outlier claim. The state did not, in its surveillance of outlier claims, did not specifically look at the coding for orthodontia claims. It expected its—
So it was the state's problem?
It is certainly in the first—
Their fault that it wasn't recognized, and no fault rests with CMS, even though we just heard from Director Yoakum, who had all kinds of concerns about what goes on at CMS, how you fail to audit, how you—
I think we have joint responsibility. What I'm saying is that in the first instance—
Sound like what you were saying was you're blaming Texas.
I'm saying we have joint responsibility. In the first instance, the state had—
You got 65,000 employees at HHS, 65,000 employees at HHS. You just said it's joint responsibility, even though you said Texas has the responsibility.
We have joint responsibility, Chair.
Okay. 65,000 employees, and no one could see this? No one saw this coming? Until it was public, no one knew about it?
We did not know about it until it was revealed. Okay. We are working in many states, and we have many states are doing predictive modeling where you can track the expenditures on different codes, and you would identify outliers. That was not done in this circumstance.
We'll be generous with the time for the ranking members, and now recognize Mr. Kucinich from Ohio.
Thank you very much, Mr. Chairman. I want to follow up on a line of questioning that my friend Mr. Gowdy began of Commissioner Jessen. Now, Commissioner, until just the day before yesterday, you maintained that the Federal Government was not entitled to any part of the $30 million UCARE transfer. Isn't that right?
That's correct.
Okay. Now, after CMS pursued this matter with you, you've apparently changed your mind, and you intend to give the Federal Government its share of the UCARE transfer. Now, I have questions about how you got to the point of believing and acting to keep all of the UCARE funds for Minnesota when many believed at the time, and you now concede, that the funds needed to be divided with the Federal Government. Now, you note in a letter to CMS a discussion of the donation announcement with Ms. Mann while you were attending a conference in Baltimore in March of 2011. Is it your testimony that you provided Ms. Mann with full information on the matter at that encounter, and that Ms. Mann then gave you an approval of your intention to keep all the funds for Minnesota?
No, Congressman, that is not what I'm saying. I did. Nancy Feldman, who is CEO of UCARE, came to my office and told me on March 14th that they were going to make this donation. I was in Baltimore on the 16th and 17th of that week. During that time, I met with Cindy Mann and people from CMS. And it was more of a, here is a heads up, we are issuing a press release today about this donation.
So when this discussion occurred, were you at a reception? When this discussion occurred, were you at a reception? Was it a formal business meeting? Were others present? Did you present a legal analysis? How did that, help me understand this, how did that come up?
This came up during, it was a scheduled meeting. We were there for what was called a PACE car event, and we were meeting with CMS about exchange-related matters, about the health exchange. So there was a group of people from Minnesota and a group of people with CMS. It was not on the agenda of the meeting. I just said it to let her know what was going on. I have never said that she said that's fine. As a matter of fact, I believe when I said it, I said something along the lines of, we may have.
So you're saying now that you didn't believe that you had some form of approval from Ms. Mann or indirectly from CMS of your characterization of the funds as a donation solely to the State be placed in a Minnesota General Fund. Is that right?
That's right.
Where did you get the idea then? That it was a donation? How did that come up?
Congressman, it came up because UCARE, when they came in, they said we are making a donation to the State of Minnesota of $30 million from our reserves. And that was really just 2 days before I talked to Ms. Mann, and that's what I knew. I did look at the contracts myself to see, did they owe us this money? They didn't owe us this money under the contract, and we hadn't asked for the money. So from my perspective,
they didn't owe you the money, you hadn't asked for it, but you wanted $30 million to go to the General Fund of Minnesota. How does that happen? I don't understand.
What, Congressman, what the UCARE told me when they came to meet with me was Minnesota had a historic budget deficit of $5.3 billion. They felt like, they had the money available in their reserves. They made a donation. But if I may, Congressman, I just want to be clear as far as changing my mind. We believed we had a bona fide donation, and there are disagreements.
What is a bona fide donation? I don't understand that. I mean, the rule is you'd have to give half to the Federal Government. Now, in fact, as early as July 2011, according to what we have, Ms. Mann began to question you, asking you for your justification in keeping the entirety of the UCARE transfer from Minnesota. Now, to me, that doesn't seem consistent with this notion that somehow CMS had known, signed off. Help us with this. Help us understand this.
Congressman, we took the position that it was a donation. CMS took the position that it was a refund and have to be shared with the Federal Government. After we got the donation, we provided additional information to CMS. We have differences with CMS, over large amounts of money often. Sometimes if we don't—
Really? Such as what? Well, give me another example of a difference you have with CMS on a large amount of money, and are you withholding that money from CMS?
Mr. Chair, if the Commissioner could finish the thought, please.
Excuse me, the gentlelady from Minnesota, I have a line of questioning here which is important for the work of this committee, and I would ask the gentlelady to suspend. Would you answer the question, please?
Congressman, it is frequent that we'll have disagreements where there are unique situations, which this was, or ambiguity in interpretations. For an example, just a couple of examples, in 2006, CMS disallowed over $19 million in the federal match, kind of regarding a supplemental payment to nursing homes. We disagreed about that. We couldn't resolve it. We went to the appeals board, and that board found in favor of the state. In 2008, there was a disagreement about $8 million in federal funds, of which we once again went to the appeals board, and the appeals board came down kind of somewhere in the middle between the feds and the state. These are discussions that frequently happen. What I'm happy about here is that we were able to, because of the 1% cap, resolve this, I think, appropriately with CMS.
So there was nothing unusual about the kind of exchange where the state claims $30 million as a donation, you go back to CMS, and you work it out. Is that what you're saying?
A $30 million donation, Congressman, is certainly unusual.
Well, this is why we're here to discuss it. I think it's unusual, but just trying to find out how it happened, and I'm still not sure. I just would like to conclude, Mr. Chairman, and say that based on a testimony that is presented here and other information given to the subcommittee, I think that the chronology of events went like this. The Commissioner or the State claimed all $30 million of a transfer from a Minnesota Medicaid managed care organization. The Federal Center for Medicare and Medicaid Services questioned the justification for claiming the entire amount for the State, rather than returning to the Federal Government its share of the transfer. And ultimately, you, Commissioner, reversed yourself, and you're now returning about $15 million to the Federal Government. Now, I'm not saying that you did anything wrong, but perhaps you thought you were doing the right thing. Somebody else is going to have to determine that. But I think in this instance, the Federal Center for Medicaid and Medicaid Services did something right, and it's important to go over the sequence to sustain that view. So I thank the gentleman for his indulgence with time here.
Thank the gentleman from Ohio. The Chair would now recognize the gentleman from Illinois, Mr. Davis.
Thank you very much, Mr. Chairman. Commissioner Justin, let me just ask you, did you seek a legal opinion relative to the status of the contribution?
Congressman, after we got the July letter from CMS taking the position that this was not a donation, I did seek a legal opinion about this. Go ahead.
This was afterwards that you sought it? Right.
After we got the July letter, but it was still before we actually received the donation, Congressman.
Yeah. Let me just say that I think there has obviously been some mistaken judgment in terms of this whole matter. But I also want to indicate that I've been looking at Minnesota for a long time in terms of its health care. And there's a great deal that is right with Minnesota. It has been a model for efficiency as a result of this tremendous nonprofit health care system efficiency that I've observed. But I'd like to hear about improving the the contracting operation. Can you speak to us about the competitive bidding process now and what it is that you've done to improve that?
Thank you, Congressman. Actually, just a month and 2 weeks after I started, in the governor's budget, Governor Dayton proposed competitive bidding for really an area that included half of our Medicaid enrollees. And the reason we did that is because, as I said earlier, we had serious questions about the excess money that the health plans were making, and we really wanted to reset and get the best rate we could but also looking at quality. So what we did was we issued an RFP, request for proposals for all the health plans to bid on our Medicaid population by county. They had to give us both the cost bids, but also, importantly, include a lot of quality information. And when we sat back to judge those bids, we judged them half on their quality and half on their cost. And after doing that, we ended up reducing the number of health plans that served in most of the counties. So we took the best bids, and we reduced the projected cost to the state and the federal government for those plans by, I think it was almost 7%, and saved over $300 million just on the competitive bidding. But then what we did was we took what we learned about the fact that obviously these rates could be a lot lower than people had thought in the past, a lot lower.
So you've recouped $73 million this year, and you've shared that with the federal government?
Correct.
Can I ask, why were the UCARE funds of 2011 initially handled differently?
Congressman, they were initially handled differently because we were told and believed it was a donation. But once we looked at the 1% cap, we realized that if UCARE hadn't made that donation, then they would be paying back $38 million instead of just $8 million to the state and federal government. So we thought it was only fair to share that $30 million with the federal government, as well as the $73 million, as well as the over $600 million that we've saved in our managed care reforms.
So this transaction came as a result of prior contractual relationships under the former administration?
Yes, Congressman. The 1% cap did because we inherited the contracts. We thought they were too generous, so we negotiated a cap with the health plans.
Did you get the feeling or have the feeling that there had been a cross-subsidizing of Minnesota's program by improperly inflating the Medicaid costs?
The program, General Assistance Medical Care, that is being accused of, it's a state-funded program. So the allegations, I understand it, is they were paying more for Medicaid to pay less for the state-funded program. That program was no longer in existence when I started as commissioner. So I didn't work at the department, so I do not have firsthand knowledge of whether that happened. And actually, Congressman, when I started, I brought in a whole new team in this part of the department because I thought we needed to change direction. But I will say, I very clearly thought that the state of Minnesota and the federal government were paying too much money under our Medicaid contracts. That's why I put them out for competitive bids.
Thank you very much. And Director Mann, can I ask you if there is a separate office of CMS responsible for fighting fraud?
Yes, there is. And also, let me try and be clear on my answer on numbers before. CMS itself has 4,500 full-time employees. Medicaid office, which I oversee, has about 350. And we have the Center for Program Integrity, Congressman, about 150 people. They are primarily responsible for fraud, but really it is, I would certainly, as the director of the program itself, see it as also good, strong financial management is my responsibility, as well as the Center for Program Integrity.
And so you have 150 people fighting fraud. That's for the entire
That's for the, well, that's country. For the Center for Program Integrity. That's actually Medicare and Medicaid.
Yes.
There's about 60 within that for Medicaid.
Thank you very much, and thank you, Mr. Chairman. I yield back.
I thank the gentleman. The Chair would now recognize the gentleman from Texas, Mr. Burgess.
I thank the Chairman for the recognition. Again, appreciate the opportunity to be here with you. Obviously, I'm on another committee, but this issue is so important that I wanted to participate today. Businessman, we've heard 3 specific cases here today, every one of which is startling in and of its own right. But tell us what you are doing and going to do at CMS to prevent this from happening and to deal with the issues that have already occurred.
Well, in terms of the issues that have already occurred, there are investigations going on in all 3 situations. Actually, reports have already been issued in the New York case, and investigations going on in both Minnesota and Texas by the HHS Office of Inspector General and the Department of Justice involved. To the extent that we determine that there are questions about any particular expenditures, we defer those expenditures. We won't pay until there's been full resolution, and then we disallow if we do not feel that there's justification for paying for those.
How many payments have you disallowed so far in Texas on dental procedures?
We have not taken the disallowance yet. It's still within the regional office to consider the disallowance.
So these clinics are still being paid?
And I believe the State has moved forward and the clinics are not being paid. So I don't think the problem is continuing. The State has taken a number of different steps to change their process. They had a prior authorization, a company that did prior authorization to review those claims. That company should have screened out and not allowed the kind of claims that went in. They obviously didn't do their job. The State has changed that contract. The State has also changed its method of payment for orthodontia services, so you weren't getting the situation where if you came in 22 times, you got paid 22 times, but has moved to a global payment. So there's been a number of changes that the State itself has taken, has made to stop the problem going forward, but we still need to see what claims were paid that should not have been paid.
Well, I certainly appreciate the work that the State is doing and their understanding of the fact that they had a problem. But you had a problem.
Correct.
And I guess my interest at the Federal level is what is being done right now to correct that problem and to prevent it from happening again.
Well, in Texas, what we first do is make sure that the problem stops going forward. So that is an important part.
So the state guys are doing that, so that makes us covered.
State does that in consultation with us. But yes, then that was our first line of.
You know, forgive me, but it just seems like there was a big failure at whoever was in charge of oversight, the OIG. This is OIG 101. I mean, Mr. Gowdy pointed out that his 15-year-old daughter could have probably picked up the problem here. This was not obscure. There's plenty of fraud that is obscure, but this was not. It was out in the open for all to see. And we talk about audits and we talk about actuarial soundness, but really that never came into play, did it? All we got were assurances that, hey, we're okay. We're doing everything the right way, and the checks continue to go out. That is a massive failing on the part of the Federal partners who were responsible for providing those funds.
We do audits of State Medicaid programs. We do look at outlier claims of State Medicaid programs. We do not do audits of every single claim in every State.
Why wouldn't these have then come to the top of the radar screen? I mean, they seem pretty obvious.
Because they were not separately coded with what was growing overall was the dental account in Texas because of major changes that the State did in its dental account. These were basically hidden claims within that, and so neither we nor the State identified them as an outlier. We do that in many instances. It is a lesson learned in terms of how to break out certain codes and make sure we're all examining those codes in a very particular way.
I'll be the first to admit that Texas used to be its own country, and in many ways we behave that way. But here you had Texas charging or paying more than the rest of the country combined. Seems like that had to get someone's attention at some level, because that is just such a stark difference. I mean, Texas was paying more than Florida. Texas was paying more than California.
And the problem, which is a lesson learned in terms of moving forward, is that it was not pulled out as a separate code, but inside the broader dental claiming. And so neither Texas nor CMS identified it in a timely way as to something that we should all look at.
2 years ago, the President identified McAllen, Texas as an outlier with Medicare spending and criticized the state because of that. And this was happening right under your noses, and no one said anything about it. Where was the integrity at the Office of Inspector General? And consequently, why has the Department of Justice been so slow to get involved in this? I respect the fact that a lot of the problems were state-specific, but you had a duty, you had an obligation as well as the steward of these funds that were going out. I mean, here you have the dentist testifying that there were recruitment activities going on at a pizza parlor to get patients to be inappropriately referred to have procedures they might not have needed on children. I mean, that should be assault and battery. People should be going to jail for this, not just we're looking into it and we hope to have some better answers for you in the future. I'm stunned by the revelations that we've had today. You have spent enormous money and press time focusing on a public hospital in Dallas, Texas. And this was happening right under your nose. You criticized the hospital because it wasn't following procedures, because it wasn't doing things correctly, and your own procedures aren't being followed. I mean, this is a classic case of, take care of your own problems first before you start criticizing someone else. This is an enormous problem. We're not obviously anywhere near the end of it, and I'm just so grateful to the committee for initiating this. I promise you that this will continue to get my full attention in my office and at our committee, and we've got to do right by the taxpayers. We've got to do right by the people who have, in fact, been harmed by these activities. Mr. Chairman, you've been indulgent. I'll yield back the balance of my time.
Thank the gentleman from Texas. The Chair would now recognize the gentlelady from Minnesota, Ms. McCollum.
Thank you. Commissioner, this was an unusual thing to have UCARE come and say, we'd like to give you $30 million, and it was a contribution. There is federal money that goes into Medicare disbursements and there is state taxpayers' money. So I'm glad you had a discussion with the CMS, and as a resident of Minnesota and as a person who looks out for the federal purse strings, I think we've come to a good conclusion with that. So thank you for everyone for their work on that. But I don't think we're going to see many donations coming forward again in the future. Could I maybe shift this a little bit to CMS and to GAO while we have them here? And I'm going to combine two questions and then just ask your professional opinion. The Affordable Care Act, which was just passed into law, will streamline Medicaid eligibility as part of the health exchanges. It's going to standardize quality measurements for adults. It's going to provide new tools to prevent fraud, waste, and abuse. So if you could maybe tell me a little bit about how you can see, and Commissioner, if you have anything to add, how these tools included in the Affordable Care Act will improve state and federal oversight in the Medicaid program. And then to GAO specifically, has GAO ever looked at the differences between for-profit and non-profit health plans in respect to fiscal management and quality outcomes within Medicare managed programs? And then to GAO, this also goes to CMS, I mean 150 employees. Every Medicare contract is different because it's different between the two states. They're constantly being renewed and refreshed. So can you provide me maybe a little more information about the challenges that you have, maybe some of the successes that you can identify in CMS's Medicaid Integrity Institute, especially as it relates to states investigating and prosecuting Medicaid fraud? Or perhaps this is grossly understaffed. Grossly understaffed, so that we can't do the very things that I agree with Chairman Gowdy on. We need to be doing handing things over for prosecution. 150 employees for 50 states, all the contracts different, constantly changing. And I yield my time to you to have a discussion.
Well, Thank you, Congresswoman. Let me just respond to the first part of your question about what the Affordable Care Act does in terms of provide some new tools. Let me identify a few of them that I think are really directly relevant to some of the issues we've discussed here. First, it requires that every state have a RAC program to look at fraud and have a modeled after the Medicare program, which has been successful in terms of bringing in a rate of return that is effective now. States are implementing that requirement as of January 2012, and it allows payments of basically dollars for collections identified by the contractors. So it's an encouragement for states to move forward in a new method for them to identify and pursue improper payments. Secondly, we have a new provider enrollment requirements in the Affordable Care Act that assure that if a provider has been terminated, for example, in Texas for improperly billing in the Texas program, that they can't start billing in Oklahoma, that we've set up a system so that states know about terminations from one state to another, as well as from Medicare to Medicaid, so that if we have problems in South Florida in the Medicare program, the Medicaid program in Florida or elsewhere also takes action to assure that that provider is no longer participating in the program. We also have in the Affordable Care Act an emphasis on program analytics to be able to detect fraud, improper payments before it occurs. That is certainly all of our goal, not just to detect it afterwards and get repayment, but to avoid it going forward.
Thank you. I've got about 42 seconds left for GAO. And all those oversight disappears with repeal of the Affordable Care Act, if GAO.
Okay. Yes. To my knowledge, we have not done work that has looked specifically at profit versus nonprofit, so I can get that question out quickly. With regard to the Medicaid Integrity Institute, some of the promising practices that we've heard from states is really just a chance to be educated on ways to detect improper payments, ways to recover, ways to analyze. And that's been of extreme benefit. The state Medicaid programs are widely varied in size and in support, and so having a federal role to provide instruction and oversight has been helpful. Lastly, I want to underscore something that Director Mann said, which is being able to look across states. That capability is quite limited right now in the Medicaid program, and it needs to be developed. Until this program has good data and strong data that allows for comparisons that can be more easily done, we won't be successful in combating improper payments and other types of fraud.
I thank the gentlelady from Minnesota, and I want to follow up on something the gentlelady from Minnesota made reference to. I think she said that we would not be having any more donations in the future. My question is a little different, which is how many had you had in the past? How many $30 million donations from corporations had you had in the past?
Mr. Chair, this is the only one I'm aware of.
So there's only one, and we are left to conclude that it was either donated out of the beneficence of the corporate heart, which isn't that likely, or maybe there's another alternative explanation, which leads me to ask this. Was there a letter that accompanied that check, or was it just a check in the mail? They offer any explanation in writing as to why they may make a $30 million donation?
Mr. Chair, there was a letter from the CEO in July, I believe, she sent to the State of Minnesota. The check actually we received in November.
And what was the explanation that the giver of the donation actually gave?
That it was just that, a donation to help the state during this budget crisis.
Right. Is there any evidence that perhaps UCARE had been overpaid in any way by the State of Minnesota?
Mr. Chair, as I said, I believe that the contracts that had been negotiated during a previous administration were too generous. I don't think they were overpaid in the sense that it wasn't; those were not actuarially sound contracts.
So there's no evidence that UCARE was overpaid and that maybe a state health plan may have underpaid?
Mr. Chair, I think the evidence would say that those contracts were actuarially sound and approved by CMS. So I don't think there was an overpayment. But I do understand that the health plans historically have said, this is once again before I was commissioner, that they lost money on the state-funded program.
So they lost money on the state. Okay. Well, can you understand at all the cynicism of maybe questioning the motive behind the corporate heart making a once-in-a-lifetime $30 million donation? Am I the only one that has any amount of cynicism about that?
Mr. Chair, I was certainly surprised when they came into my office to tell me about the donation. It was highly unusual.
Director Yoakum, do you have any experience with the beneficence of the corporate heart making a $30 million donation simply because the state wasn't able to manage its finances appropriately?
No, sir, I don't.
Do you happen to have a copy of the letter that accompanied the $30 million donation?
Mr. Chair, I don't have a copy of the letter here. As I said, I know that there was a letter in July, and we got the donation in November.
And is there any chance that letter referenced overpayments? Actually, I think there's a really good chance that letter referenced overpayments. I think there may be like a 100% chance it referenced it. So given the fact that the donation was for overpayments, why would there be any argument that CMS wasn't entitled to half of it?
Mr. Chair, they characterized it as a donation. They were not under the contract. They were not required to pay it back to us.
Does it really matter what you call something? I mean, I could call the check I just had to write the IRS a donation. It's not a donation. I mean, come on. It's $30 million. No corporation is ever going to give a state $30 million out of the benevolence of their shareholders' hearts.
Mr. Chair, it's a nonprofit corporation. I thought it was very generous. I acknowledge there are reasonable positions.
Well, would you acknowledge that it may very well have been because they had been overpaid systematically? Isn't that a little better explanation than beneficence?
Mr. Chair, I believe they were paid according to the terms of the contract.
Well, then why would they say
I believe those contracts were too generous.
Why would they say they were overpaid?
You would have to ask UCARE about why they phrased it that way. They told me it was a donation. They weren't required to make it.
Okay. The gentleman from Minnesota.
Thank you, Mr. Chairman. Commissioner Jessen, could you talk a little bit about what Minnesota has done in the Dayton administration to try to be more efficient and to give greater value to the taxpayer vis-a-vis the Medicaid program?
Certainly, Congressman Ellison. I spoke earlier about competitive bidding and really trying to get better value and recovering a lot of money for the taxpayers through that. And the 1% cap, where we, in addition to the $600 million through our managed care reforms, about $73 million through the 1% cap. But there's some additional things that go beyond just money, but that we believe will save money as well that we're doing in Minnesota. You mentioned one of them, our Hennepin Health projects. And that's where we are contracting with Hennepin County on a capitated basis to serve some of the poorest people who make less than $8,000 a year, those who use a lot of our social services. And at least our preliminary, we just started that in January, just 1 year after the governor took office. But preliminarily, we believe they will better serve those folks and save money because we're actually integrating social services with our health care. We're starting health care demonstration projects where we are We will, by the end of the year, we hope, have contracts with 9 different provider groups where we are directly contracting with providers, changing the incentives once again so that they share any savings that they get, as long as they meet our quality measures. And those are providers that are agreeing to care for populations, kind of in Medicaid, ACOs, all around our state, very different types of populations. We believe there's a lot to learn from what we're doing.
Now, earlier on, one witness, when I asked him, do you agree that Minnesota's move to competitive bidding is beneficial, that witness's response was no. It's pretty flat, no. I guess my question is, do you agree with that? And if you, and would you agree then that do you think that the competitive bidding process can be improved even more by maybe even allowing more bidders? I think the witness said that it was limited to the 4 HMOs. I think I got that right. And so could it be improved if there were more bidders and allowed access to the program?
Congressman, I think that the competitive bidding was a success. It was a success for quality care, and it was clearly a success for taxpayers. But I think we
$500 million, right?
Yeah. But I think we can improve it, and we are going to be expanding it. We are expanding it into greater Minnesota where there's enough competition, and we are opening it up. Those who won the bids, and there were typically 2 in each county, were some of the major health plans, but we are opening this up. We want to increase competition because we think it's a good way to get better value for taxpayers. And
Commissioner, I got about a minute and about a little less than 2 minutes. I was hoping to get your impression on this question. I believe that the witness that I was referring to, Mr. Feinwalks, and I do want to thank him for being a vigilant steward of the public dollar. We want to encourage people to step up, but I'm trying to understand this, so I just want to get your opinion. He pointed out in his testimony that a 2008 report by Minnesota's legislative auditor found the state's payment rates to be high compared to other states. Do you agree that the state's recent, I mean, what do you think about that? Are we doing better? Are they high? Are they getting lower? How could you comment on that?
Congressman, I agree with actually what the legislative auditor said in that report, which is that Minnesota's rates are higher, but they're probably higher because, one, we cover more people with disabilities in Minnesota than in many other states. And that's more expensive. And we also cover a lot more benefits. That's a choice our legislature in Minnesota has made to have broader coverage. And that is, I think, a major reason that, that it's more expensive.
Okay. I yield back, Mr. Chair.
The gentleman from Minnesota yields back. On behalf of all of us, we want to thank our panel of witnesses from taking time out of their busy schedules to appear before us. We look forward to seeing you again soon, either at this committee or another. And with that, the committee stands adjourned.